Good afternoon, everyone. Good afternoon. So, are we feeling hungry now? No, right? So, I think my session is going to be shorter now because of three speakers already done my actual 10-15 slides introduction about the different types and what all things happens in each type. I think Madam Shirisha ma'am and the other madams already covered. So I'm going to reduce it and speak about more on rehabilitation. Before going to that, can we have claps for all the participants who have come here? I want to have a little bigger claps, the louder one. Can we show we have better than this energy? Can we show that we have better than this energy now? 1 second, claps. Yes, there is an increment. So we'll see in between of the claps. Let's use our energy to have the claps through the claps. Thank you so much for that. And can you have claps for all the management who organized this conference or the national conference or seminar? Yes, thank you so much. And thank you so much, ma'am, and all the seniors, doctors and madams here for bringing us, all of us together. Like all Rehab people bringing us together and talking on understanding. I have many learnings. I'm lucky that, I just planned to come 2 hours early, so I'm sitting and many points I picked up from the previous speakers, which which helps me to guide my patients who are coming to me. Yes, so already the introduction is given. So, but I want to emphasize that as a physiotherapist, though I'm a physiotherapist, but I'm little different from physiotherapy profession now. Though I'm using my physiotherapy as a core, so assistive technology I have made as a more predominant practices. Assistive technology, which is going to be future of assistive technology. Any field, assistive technology is going to be future. AI and assistive technology. So it's not all I'm telling. I'm going to show some of the slides. This is WHO, World Health Organization, saying which is going to be useful for every one of us. So I've done courses called Assistive Technology Professional, that is ATPResna, who certifies us and in the Assistive Technology for the locomotor disabilities. Yes, I worked for Mobility India. Hope this is working. Yes. So I worked for Mobility India. 1 minute of introduction of Mobility India. Mobility India is an NGO. It's a non-profit organization. Last 30 years we're working for a person with disabilities. Is any disabilities, polio to amputation, muscular dystrophy, cerebral palsy, many conditions which has a locomotor disability, actions, movements, who has issues with the movements. For them we were working. Though it's a Bangalore-based organization earlier, whole India we were providing services. I'm responsible for South India. I will travel to Andhra Pradesh, Kerala, Tamil Nadu. We go to it's a severe approach, community-based rehabilitation approaches. We work with the local NGOs and we go and identify the person with the disabilities, and they identify for us and we do assessment and provide the rehabilitation services, including physiotherapy services as well as devices, whatever for the functional mobility point of view. Yes, now last 1.5 years, Mobility India now existing in Hyderabad now. So last 20 years I'm working for Mobility India Bangalore. I studied there and I got job there and just working there. I could not change the job because of the enjoyment, the satisfaction I'm getting in this, I could not change. Then ultimately I wanted to come back where my parents, I'm from Sirsila district. So I want to come back, so it is too far and my parents are getting old. So I could not, discharge and come out of that organization. I brought that organization to Hyderabad. So now we have a branch here, Mobility India, Hyderabad we have here. So last 1.5 years here. So any services regarding the Assistive technology, so we are there here. Yes. Coming to the topics today, that is I'm going to cover up next to 30 minutes. The introduction to the muscular dystrophy is done almost. I'm going to just go to do a small glance on that. And assistive technology services and the key orthotic services, what is available for the person with the muscular dystrophies, and key wheelchair services and key assistive devices. In all of this, I'm going to talk. It's not that what I'm doing it. Of course, devices available I'm going to show, but I also am say what is happening in the worldwide, what WHO is doing, World Health Organization is doing. So how much research is going on, how much what are the guidelines developed, and how much training programs are happening for the rehabilitation peoples. I'm going to introduce. I think most of you are medical background doctors. and some of your parents and some social workers is for everyone. I mean to say, this information what I'm going to give is a mixture of people, but it's for everyone, which is going to be useful. I can see some of your parents also sitting here. Yes, sir. So it is going to be useful for everyone. You can also learn and understand what is WHO makes for any guidelines or any tools for most of the public to available. Yes. Yes, already we have introduction. Is a problem with the muscular dystrophy in the genetic cause, and is a genetic mutation happens, and mainly affects the dystrophin protein, and it affects majorly skeletal muscles and also laterally respiratory muscles, and the cardiovascular system get effects afterwards. Then the severity is based on the severity and onset based on the different types, as already we have seen. Madam also explained to us very well, so detailedly, and also all of this condition, assistive technology and physiotherapy services, including both of them. So ultimately, these services in the rehabilitation is we are trying to make the quality of life get better. So the last 3 sessions, I think majorly they are discussing about the internal medicines. So I'm going to talk about the after giving the internal medicine, but still there are symptoms which cannot be, we cannot remove it. So some of them how to manage with the existing symptoms or weaknesses by adding some kind of external assistive device or some support. So that's what we are going to talk. Yes, these are common symptoms majorly in the muscular dystrophies. That is muscle weakness, difficulties walking and frequent fallings, and delayed motor skills or delayed milestones we say, and pseudo-hypertrophy. The muscle is getting hypertrophy like bodybuilder, but actually there is no strength. I mean, actually there is no purposeful strength, but it's getting bigger and bigger. That is pseudo-hypertrophy. Yes, again after some time they will have a difficulty in swallowing and breathing. And scoliosis is a major thing, which is a secondary problem develops afterwards, which we need to prevent as a doctors and as a therapist, as a assistive technology professionals, as a parent, as positioning. So one of that we can prevent it. Which if we prevent it, the better lung function can be there. That's also we are discussing. Yes, again cardiomyopathy also can happen. So these are the common symptoms which you see across the muscular dystrophy conditions. Yes, the diagnosing has already been very well discussed. The diagnosis happens in a physical examination by assessing physically with the muscle strength, and some specific test we conduct, and also genetic test, through genetic test, muscle biopsy, EMG, and blood test. So all of this test combination or mixture of any one of them also can be used to understand and diagnose what is muscular dystrophy. So there are all of these types already madam discussed case by case. So different types and their prevalences. So I don't want to take much time about this. Yes. So of any muscular dystrophy, the management is of course medical management and the rehabilitation is combination we need to, as a team we need to work on. There should be a neurologist, there should be a cardiologist, pulmonologist, physiotherapist, occupational therapist, and assistive technology or orthotist and prosthetist. All of us together should work to have a better quality of life. So these are all the varieties of team we are going to work together to have a better quality of the life of the child. Yes. So what are the challenges whenever we, as a parent also you are going through, or you are understanding, as a therapist, as a doctor we are going to see, what are the challenges? The first challenge is this condition actually is progressive in nature. Today one way that what assessment we do, but after 1 year, after 2 years, gradually when you see after some time, it is going to change the abilities what we had assessed 1 year ago. So this is progressive nature. Ultimately the therapy or the intervention, the devices, we have to keep changing it. This is one of the challenge. So it is not, if I give for example, as a therapist I will prescribe wheelchair. Today the wheelchair condition, the way I am giving prescribing based on the condition of the child. But after some time, the wheelchair may not actually suits after 1 year or after 2 years. I need to keep changing it. So that's a progressive nature. That is the challenge. One of the things happens, and ultimately affects again the cost of the device. Next one is this affects not one area. It affects the muscle mobility and the respiratory system and cardiovascular system, heart. So all of this affecting again is causing the further weakening. Not only muscle weaknesses, general endurance also comes down because oxygen intake also reduces. And which is contributing again the psychological challenges. People know, this could be parent side or the child side, they get frustrated or they may feel no, nothing is happening and getting weaker, there is no progression. If I do treatment after 1 year of therapy, 1 year ago and now the ability, usually other conditions will differ, will get better. But in this, as progression or weakening is happening, then people get frustrated or psychologically they affect and they go for depression. So these are all the challenges, among the challenges as we rehab people as parents. Rehab people means it's not only medical doctors or the rehab, the physiotherapist. Also we enroll or we ask the therapist and along the therapist parent also, social worker also to be part of it. So all of us we need to work and work through the challenges. Yes. As in the morning session also we are talking, early identification is very important, early intervention is very important. So that has a better result in the or better management of the child. So also similarly other medical treatment, even early in physiotherapy services, early devices, introducing the device is very important. So which also helps in the slowing down the progression, disease progression and maintaining the function. The function can be maintained longer duration and the abilities can be maintained longer duration. So that's how we need to introduce early identification and early use of these devices. Yes, in assistive devices, I would like to categorize into three, which is a major topic now, which I'm going to cover. That is orthotic services, wheelchair services, and ADL assisted devices. Okay, so these three components are what there are many other, but these three which is majorly required for the children with the muscular dystrophy. So what is assistive technology? So assistive technology is nothing but is a device or is idea or any knowledge or skill which making someone to do better performance. Okay, so these devices could be a simple aid like it's like a cane or reading glasses. So most of you are using specs, right? So we consider as a assistive device for you, that is. So your vision is getting better. Similarly, someone is walking, difficulty is that if you are adding some walking aid, walking cane or walker, so that sometimes simple orthosis, providing their walking abilities get better. So simple devices too. Even complex technology like powered wheelchair has a joystick and has a standing. I mean, with the joystick only they can stand up, the joystick only they can tilt, they can sleep. So they are complex rehab technology also is a assistive technology. So all of these devices has to be customized according to the requirement of the child and body size and lifestyle, physical abilities. Many things we need to consider and see and provide them a customized one. And this assistive technology is not one area; it is most of the areas: vision, hearing, cognitive, motor, environmental. Even someone wants muscular dystrophy to come onto this dais. So this modification to the dais, I mean, also is one of the assistive technology. Putting a ramp onto this. Temporary ramp or permanent ramp. These are all called as a environmental modification assistive device for environment. Yes, these are some of the categories I would like to say here. One is mobility aid, someone to move one place to another place. Next one is environmental adaptations, also assistive devices, which is predominantly required for the muscular dystrophies. Among all this, and self-care aids. The self-care aids like brushing device, or dressing, combing, these are all called self-care devices. So morning what you have done within half an hour, you have to come to conference, got up late and slept late and got up and you have to come back and catch the auto or your taxi, then you got up within half an hour you have done it. But the child with a weakness or child with a delayed milestone, they do this task very slowly. Okay, for this they require assistive devices, combing, dressing, bathing, all of them. So all of these devices called self-care devices. Then recreational aids. Also we can have devices which make them involved in the fun activities, fun generated activities. It could be cycling, games, so any games. So that, but that has to be modified, adjusted to their abilities point of view. So we say regression therapy, play therapy point of view, adapt each and every, like carrom board to chess, table tennis, different games we modify to the according to their abilities. Yes. So customizing assistive technology also involves again different steps. One is the AT evaluation by the rehabilitation team. So each client has to be assessed and informed and find out whatever according to their lifestyle, according to their abilities, and find out the best solution. First assessment, even for the assistive devices. And it has to be tailor-made. Once done it, the ready-made device is what is available in the market. We cannot just bring it and give it to the client. We have to customize it, modify it. Even, for example, in the wheelchair, the size of the width of the seat has to be modified. The straps need to be added. So whatever is required for them, that has to be modified and given to the client. It's called tailor-made. Then, again, for muscular dystrophies, it doesn't end again there. We have to every 6 months once, yearly once. Again, we have to reassess and check whatever device is given 6 months back or 1 year ago, is it working, or we need to change it, or we have to modify it. So in the customized technology, we can every time assess it and modify it and reassess it. So that's how we need to do it. So, as I told, first top is orthotic. Do you understand what is the meaning of orthotics? Orthotics? Yes, orthotics means nothing but the device which is applied to the body. I think some of you have seen, no? For knee pain means you use the brace. Splints. Yeah. Yes, splints, for leg splints. And sometimes you have flat foot. Some of you may be having flat foot. The insoles are also orthotics. Even cricketers, bowlers or footballer players also use that, which is supporting the body structure to maintain the anatomical formation, whatever anatomic structure we have, that has to be maintained. For that, some external plastic item is applied to our body so that it will be maintained. So that is called orthotics. So in muscular dystrophy also, as madam was saying, we have contracture. There will be a chance to develop the contractures, especially in the ankle. Okay, it goes like that. So that has to be maintained or prevented. That can be prevented with the orthotic devices. Aim of this, enhance the function and delay the progression of the disease or deformities, and supports the independence. Whatever independence presently we have, that independence it has to support the device. Again, the device should not prevent the independence by adding it. It has to support it. So that is the aim of the giving orthotics. You should not prevent it for any quality of life when you are giving the device. Yes, orthoses are often combined with the physiotherapy and other rehabilitation. It's not that orthosis is not complete treatment. We need to add orthosis as well as physiotherapy to continue with that. So orthotic, this is the example picture, sir, which can be provided to the ankle. Okay, if someone's ankle is deforming down, is going down, and the child cannot put the heel down, so they are standing like that. If you provide as a resting splint, as madam was saying, no, night we have to provide the splints of few of them, or some of them for walking also we can provide. So this splint has to be, when you provide it, that ankle will be maintained L angle, that 90 degrees. So this is called orthosis. And orthosis are found, the correct orthosis also should be provided, which is for the positioning as well as for the walking point of view. We need to decide and provide it. So here, maybe physiotherapist or orthotist understand, both of them look similar. It's like L shape, plastic, padding is there, straps are there, look similar. But I put together there, so there is a technical errors also there sometimes when you provide it. So it's called trim lines. The trim lines, wherever the toe break should happen, the break should happen. Okay, there will be anatomical structure it has to maintain, the movement should be allowed. So this usually we say wrong. The trim line should not come till the toes. It should finish before the toe joint, a metatarsal joint. So can you see there? So that you have toe break, and when the child is walking, and the rhythm, the cycle, walking gait pattern will be maintained. Technically, and we need to assess and provide proper orthosis. That is one thing we need to take care, and go to the proper trained orthotist. I have found some of them not trained means RCI certified course, RCI Rehabilitation Council of India. Whoever undergoes or certified by them only we need to go. They will have a better knowledge. Some people, this is easy, looks like easy. The people know 6 months, 1 year works as a technician under someone, and they start open their own, and they do all these blunders. I found many orthoses. When yesterday also I found in my organization someone has come and with the wrong orthosis. Looks similar for them. Yeah, that is for military. I was staying in a military zone. The military person has come. They got from somewhere and they shown the orthosis. We have orthosis. When I've seen it, it's wrongly fabricated. And very small child, foot drop. The injection is given and foot drop happens, and they give heavy orthosis. Its independence should not stop. It support the independence. So that's how I'm trying to say. The orthosis should be provided correct one. Yeah. Sometimes KFOs we provide, like if they undergo any surgeries or anything, we can provide the long KFOs. Above knee, very rarely we provide. If it's only surgery, post-surgery, just for standing purpose we provide. Mobility point of view will be difficult, but as a resting point of view, we can provide long braces. But otherwise, you have to provide as much as small braces. Above the knee braces usually not recommended much, other than only special cases. Yes, next one is spinal braces. If anyone, if we finding any children developing scoliosis, already started, then you have to prevent it and maintain it. But prevention, before coming, you are only providing postural support devices is very important before scoliosis or before spinal brace. Giving spinal brace like a plastic jacket wearing is very difficult, right? So I have come for conference with the jacket. Since morning I'm actually discomfort. And putting a jacket, okay, I have to look decent, not in front of you. I have come with this. Okay, I have purpose. But jacket, whole day, 24 hours, plastic jacket. It's very difficult. Prescribing is a last solution, but prevention not to come to scoliosis for that proper postural management. That means properly sitting, properly lying down, proper therapy, strengthening, all those things you should do it first. And don't give, I will come to wheelchairs. Parents are the usual people think that, okay, child is growing, so let's give a bigger wheelchair. So that by the time 5 years, okay, the wheelchair can be used. But they're not thinking now. But because of loose wheelchair, by the time 5 years, what happens? They develop the scoliosis because it's loose. So we have a strength. What happens? Sometimes you are holding this side, sometimes you are holding this side, and you are managing and trying to manage it. Okay? So these all need to be, consider you have to provide the wheelchair as compact as possible. Not to develop. Actually postural management point of view I'm saying, because they have muscle weakness, progressive, and their sitting tolerance will be lesser because of they get easily fatigued. Yes. So spinal brace has to be provided when it's required only, but prevention is the best I'm talking. So next one is wheelchair service provision. Yes, wheelchair service provision, it is a big headache for the WHO. It's not only for in India. Wheelchair service provision was the 2006-04 when I was just joining Mobility India, and I've seen it. It was a big headache, and there was no solutions. And everywhere, not only in India, everywhere in developed countries, wheelchairs seen it as one donation item to take a picture. And it looks bigger, and people may sit and take a picture, and we don't know what wheelchair is given. So that's the reason the wheelchair WHO has taken serious steps, and I will show some of the guidelines what have come. So before that, I will say what is the wheelchair service provision. The aim of the wheelchair service provision is to improve the mobility. First aim. Improve the mobility means, now child is without a wheelchair, what is happening? Maybe inside the house only. The energy is spent. But when I give the wheelchair, the child should be able to go to the school, able to go to friend's home, a park, a temple, or wherever you're going functions, they should be able to come with you. So that's the mobility is called, one place to another place to go. So it enhances the easy way of mobility, number one, and enhance the independence. And after made to sit in a wheelchair, and the child should not be dependent on someone else. So it has to make them move easily one place to another place. Independency should enhance, and as well as promote better quality of life. The child should feel good when he's sitting in a wheelchair. It should not collapse and sit. No? The what is called posture and his dignity point of view, it looks fit and everything. If I'm wearing the loose jacket, what happens? Okay, loose, what happens? You will not feel that confident. Everyone is wearing proper shirt and proper fit one, right? So looks confident and you look dynamic that way. So similarly, the child when they're sitting in a wheelchair, the wheelchair has to provide that is feeling fit. Okay, it's not full loose and collapsing in that. So I'm trying to say that you start to promote the better quality of life, and that is the meaning. Yes. So there is a global need in the wheelchair. According to the WHO, it is identified that 1% of population in the world require a wheelchair. For every 100 members, 1% require a wheelchair. It is estimated, and it is there and requirement. That's why WHO taken it very serious and understanding. And among them, only 5 to 15%. Country to country changes. Like some countries, only 5% of them getting a wheelchair, and some countries 15% maximum. So that's need to be addressed. That means 85 members are not getting wheelchairs. So this has to be addressed by. That's why WHO has taken the actions. So according to WHO, in the world population, 10% of us are with the disabilities. But our Indian census is saying about only 2 to 2.5%. Where is missing other 7%? According to WHO statistics, 10% of us among public, among 100 members, 10 members are with the disabilities. Getting that point, everyone? Yeah. But our Indian census saying, Indian populations, we are so dense in Indian population, lot of low economic background families we have. but India has only 2.5% of populations are with the disabilities. Among 100, only 2 members are with the disability. Do you agree with that? So that has to be, the census taking need to be, taken well, so that to identify hidden disability conditions, so many things are missing out. Yeah. So ultimately what is happening with this? So government gave 3% disability reservation. So if it show 10%, then they have to show 10%. So that census has to be little more get better. So the funds and the facilities for the disability rehabilitation or services will get better, the fund wise and the reservation point of view. Yeah, but still among these two, around 54 lakhs wheelchair requirement is in every year in India. So that much requirement is in India if you see. The world is so much. Have you seen anyone using a wheelchair and coming to you? Coming to you means not as a patient, as a colleague, as a friend, as a family member, as a schoolmate. Anyone is there like that? Or a neighbor? Or a morning walking time, anyone is coming with a wheelchair with you? I'm telling you, friend, colleagues, anyone is there? Roommate? It is very less. I can experience one or two. Because 85% is actually wheelchair who required not getting the proper wheelchair. Because they are not coming out, though they have potential. Okay? So that's a challenge we need to do in India also. Many things are happening. But how do they get a wheelchair in India? Commonly? Yes. In a camps. Big camp, truck of wheelchairs will be coming one side, and many vehicles of users are coming, parents and users are brought there, and one VIP team will be sitting and standing there, and the distributions will be given. So distribution model is adopted in the wheelchairs, which is actually not serving the purpose. Okay. Donors are good heart. Donors are having good heart. It could be government or private. They wanted to give something to the people who required it. Okay. But you are missing the professionals' involvement. Someone, known person has to assess the person and pick the right wheelchair, which is missing out. That's what. These are my own camera. I have seen it in one of the Karnataka camps. Everyone has a good heart, but only thing is, don't know what exactly is supposed to happen. In 2007, these pictures what I have taken. Can you see that pictures and understand what wheelchair looks similar, right? One type of wheelchair is given to the different child at different disabilities. Okay, and any wheelchair is fitting them. One feet is hanging, one hip is coming out, one is totally inside the wheelchair. Wheelchair is so big and small is, so small the child is. And one child is so thin, is leaning one side. After some time what happens? Scoliosis, hip deformities. So these all may happen. So with this approach, what is happening? Wheelchair distribution model. Ultimately will take, with the respect to the organization, respect to the donor, and respect to the social worker, we go and take it, but after coming they are not able to use it and they are scrapping it. Okay, I am not saying that, it is one of the studies say. In Tamil Nadu, one of the studies conducted, they are saying only 7% of wheelchairs are actually used well. 93, they sold it, given to neighbor, or occasionally used means when mother is only they will use it, otherwise no. There is no independence, then why wheelchair is given? Like that. So this is a study, it is there in the, anyone want to do research and you can see that. Based on all of this, then WHO become very serious in 2006. One of the census conference happened in Bangalore, Mobility India, and based on that, released in 2008, wheelchair guidelines. How a wheelchair service should happen. Wheelchair is one of the assistive technology, right? So how, this is the first step one I am telling, now assistive technology will come later. Step 1 started in 2008, WHO guidelines have come out.
Can you stop for a minute because the card is done?